But welcome. This is a special treat tonight. So instead of just the one lecture going over a topic, you get a 4-for-1 deal tonight. We had the Scleral Lens Grand Rounds from GSLS poster session just a few months ago with Dr. May Eiampikul, Diana Masolak, Dr. Katie Kwan, and Dr. Wincy Chung. We can go ahead and move forward and we'll kind of give everyone an overview of these four awesome doctors. So for Dr. May, she is an optometry resident at Wilmer Eye Institute, Johns Hopkins, focusing in both primary eye care optometry and cornea and contact lens. She graduated summa cum laude from Boston University with a degree in human physiology, and then worked closely with optometrists and ophthalmologists at Boston Medical Center, providing eye care to the underserved communities. This experience inspired her to pursue optometry at NECO, where she graduated with honors and earned her doctorate in optometry. Dr. Diana is a cornea and contact lens resident at Illinois College of Optometry. She's from the Chicagoland area and obtained her bachelor's from University of Illinois and then graduated from the Illinois College of Optometry. She's an avid weightlifter, moviegoer, enjoys crafting new dishes. I love this comment while burning a good amount of them. I guess you always burn stuff when you try something new. She has an interest in working with patients suffering from corneal ectasias and corneal irregularities due to autoimmune disease. Our next doctor is Dr. Katie Kwan, born and raised in Canada, where she completed her undergraduate studies before earning her doctorate optometry degree from Illinois College of Optometry. She further specialized in pediatric optometry and completed her residency at Southern College of Optometry in Memphis and is currently pursuing a fellowship in medically necessary specialty contact lenses at the University of Illinois, Chicago. Her clinical interests include pediatric eye care, management of ocular surface disease with medical necessity contact lenses, and myopia control. And last but not least, to round out our four presentations is Dr. Wincy Chung. She received her Doctor of Optometry from the University of Waterloo and is currently doing her cornea and contact lens residency at Mission Eye Care Center for dry eye and corneal disease in Calgary, Canada, pursuing a fellowship of the American Academy of Optometry and the Scleral Lens Education Society. Awesome. Going to financial disclosures, none to discuss. Next, we'll talk about kind of Q&A feature. We will do all the questions at the end. So we have 4 different presentations going into their case. Feel free to type in questions in the Q&A as we go. I'll kind of take a tally, and at the very end, we'll leave about 10 minutes to go over questions and ask each of the doctors. For CE credit, remember we have to stay on for the full 50 minutes, and the next handout or the next slide will tell you a little bit more about how to get CE. We send a CE a couple weeks afterwards, but if you have the OE Tracker app, you can get App Store. At the very end, there'll be a QR code that you scan, and then everything will go directly there. Moving on, I will let Dr. May Eiampikul take over and present the first case. Thank you for coming on.
Hi everyone, my name is Dr. May Eiampikul. Thanks for having me. I am the current optometry resident at Wilmer Eye Institute, and today I'm going to talk about a rare case of cranial nerve 5, 6, and 7 dysfunction. I have no financial disclosures. The learning objective for today is to review neurotrophic keratitis and discuss the challenges in treating patients with neurotrophic keratitis. Also, to discuss current novel treatment plans and using scleral lenses as an effective long-term management. And, let's go back. We have right here a 64-year-old African-American male who presented to clinic after noticing a white spot on his right eye. He also reported blurry vision and redness in both eyes, and very important, denied pain. Pertinent history is back in 2006. His job was to lay the sheetrock on the ceiling, and unfortunately one day the sheetrock fell and he sustained skull fracture damaging cranial nerve 6, resulting in a brain contusion with cerebrospinal fluid leakage that damaged cranial nerve 7, which then lead to total facial paralysis. He also had undergone bilateral temporal tersography. And just of note here, this man has not blinked or closed his eyes since 2006. He also has type 2 diabetes for over 10 years as well. The initial visit with me back in July, as you can see, the vision is reduced in both of the eyes. He was unable to abduct both of the eyes due to bilateral cranial nerve 6 palsy. We weren't able to get pressure on the right eye, and everything else was pretty much normal. His slit lamp exam here, both eyes show lower lid retraction with weak blinks. However, he did have good Bell's reflex. And what Bell's reflex is, it's the way the eyes protect itself. So every time you blink, the eyeballs then roll upward. He also has lagophthalmos, conjunctival temporal tersography, rolled puncta, 1+ blepharitis, injection in both of the eyes. The right eye also has epithelial defect inferiorly, and the left eye has a large, thick blood vessel going through with some pannus surrounding. Both eyes are very, very dry as well. I have a picture showing right here. And as you can see, the reason he presented to clinic, it's the white spot on the right eye. And you can also see the bilateral temporal conjunctival tersography with the large vessel in the left eye as well. And the punctums are rolled out. And this next one here, that's a fluorescein staining of both of his eyes, where I just wanted to show the extensive of the corneal irregularities and the dryness. And I am on a time crunch here, so we will skip the fun differential diagnoses part. And let me change here. Okay. So neurotrophic keratitis, the definition of this is corneal degenerative disease associated with dampened or absence of corneal sensitivity. So just a reminder, our patient had severe dryness in both eyes and an epithelial defect in the right eye, but he reported no pain. This can be caused by anything that damages or disrupts corneal innervation, most commonly herpes simplex or herpes zoster. And for the pathophysiology of neurotrophic keratitis, corneal innervation is important in providing trophic factors which help to maintain a healthy corneal epithelium. Corneal epithelial cells then secrete neurotrophic factors, allowing corneal nerves to regrow. This interaction and cycle is very important in maintaining corneal homeostasis and stability. Therefore, a disruption can cause loss of innervation, resulting in decreased metabolism and growth of epithelial cells, leading to breakdowns and hindering of corneal healing. Ultimately, all this can result in persistent epithelial defects, ulceration, stromal melting, and perforation if left untreated. For this next slide here, I have the 3 stages of neurotrophic keratitis. Stage 1 is characterized by epithelial changes such as PE and superficial neovascularization. Stage 2, you'll see persistent epithelial defect. And stage 3, there will be presence of ulcers, which can lead to stromal melting and perforation. And of note, some vision loss can be found in all of these stages. I've also listed the treatments for each of these stages below the pictures as well. We'll discuss them more in details in the next few slides, but I just want to emphasize that in all of these stages, aggressive lubrication is very, very important. In terms of possible treatments, we have bandage contact lens or scleral lenses. There's also autologous serum tear eye drops, which are produced by sampling the patient's blood, removing cellular component via clotting, centrifuging, and then diluting it to specific concentration. Serum tears are great because they have similar osmolarity, pH, and composition to our own tears. It also contains growth factors and vitamins. And it also contains IGF-1, which is not found in our own tears, but this helps to upregulate the growth and migration of corneal epithelial cells. Other treatments include surgical tersography, Botox injections. There's also amniotic membrane transplant, conjunctival flap, and corneal neurotization. And right here, there's also Synogermin, which is the only FDA-approved treatment for neurotrophic keratitis. It is a recombinant human nerve growth factor topical eye drop where you will prescribe it 6 times a day for 8 weeks. And what it does is that it helps in the rate of corneal healing and slower disease progression. However, you should avoid using this in conjunction with steroids or eye drops with preservatives because that can hinder the healing process. And while Synogermin, it is a great treatment for most patients with neurotrophic keratitis, its efficacy may be limited in cases with severe corneal innervation loss, such as from traumatic cranial nerve 5 injury or limbal stem cell deficiency. This is because in order to regenerate nerves, there needs to be some nerve function left intact. So if the trigeminal nerve is completely severed or non-functional due to trauma, the ability of Synogermin to promote regeneration is significantly reduced and can only provide temporary relief. And this then brings me to my next slide on why it is very difficult to treat patients with neurotrophic keratitis. It's all about expectations. It's very important to educate the patient that they will feel worse before they feel better, which would bring them back to their baseline prior to starting the treatment. In other words, your patients will hate you because you're putting them through all the treatment plans and making them feel worse when they were feeling fine before they walked through the door. This is because as patients regain corneal sensation, they will start to feel all the discomfort and pain from their compromised ocular surface. This then makes treating patients with neurotrophic keratitis very, very difficult because it can lead to poor compliance. So it's very important that you talk to your patients, let them know about all of the things that's going to happen, so you ensure that they will stay on track with the treatment plan. And now we'll go back to the case. I just want to quickly go over the follow-ups for this patient to emphasize the difficulty with compliance when it comes to patients with neurotrophic keratitis, as we previously discussed. As you can see, we have the initial visit back in July. There was epithelial defect in the right eye. We then decide to start patient on moxifloxacin and bandage contact lens. 2 follow-ups later, the epithelial defect resolved. We then said, okay, let's stop moxifloxacin, emphasize lubrication. We then want to start Troverdex after and afterwards, perhaps Oxervate. And I have crossed things out here. Everything in red is what the patient did not do. And now we have the follow-up right here. Everything is stable. We then told the patient again, okay, stop moxifloxacin. Let's aggressive lubrication. And at this visit, Pros fitting was also initiated because we wanted to have all the information at hand and be ready to go when we're ready to order, because we need to go through worker comp for this patient and that can take some time. And we know at this point that his compliance with medication is not the best. So at his follow-up, again, as you can see, compliance is again poor. There is new epithelial defect in the right eye. And I'll skip these parts quickly. Okay, and now we have his December visit. At this visit, everything is looking great, but note that he will be lost to follow-up for 2 months. And he came back in February with a new epithelial defect in the right eye. But because 2 months has passed, we're able to finally get approval from workers' comp to order Pros lenses for him. So we ordered the lenses here. And let me show you, this is the baseline pentacam that was taken like 2-3 months ago to show how irregular his cornea is. This picture was also taken from the initial fitting that was done 2-3 months prior. I don't have a good picture of the lens on the right eye, so I'm just showing the left here. And in this case, Pros lens was selected for its advanced customization to navigate all the irregular corneal scarring and surface irregularities. Another reason why we decided to go with Pros lenses for this patient is because of its large diameter range. And since our patient's main issue is lag ophthalmos, we want to ensure that we're able to cover as much ocular surface as we can. And this is the lens on his eye, or before that, Let me go back a little bit. Note that his vision with glasses is 20/40 in the right eye and 20/30 in the left eye. At this visit, there's no epithelial defect, but severe dryness in both of the eyes. So we chose a 18.5 diameter, very, very large lens, but again, we want to cover as much surface as we can due to lack of ophthalmos. And his vision his vision with the lens is 20/25 in the right eye and 20/20 in the left eye. This is the best that this patient has seen since 2006, and hopefully with the lens on, he will not he will no longer get any epithelial defects anymore. And we also emphasize heavy lubrication whenever he's not wearing the lenses. I actually wanted to share a picture of his ocular surface after having worn the lens for 2 weeks, but he rescheduled his appointment with me for last Thursday, so we won't be able to share that today. And key takeaways from this presentation is remember that patients will feel worse as their cornea regains sensation during treatment. And the limitation of Synergermin is that even though it is a novel therapy for neurotrophic keratitis, the efficacy for severely damaged cranial nerve 5 is very limited since viable nerves are needed for the medication to fully work. While addressing immediate vision-threatening issues is very essential, having long-term preventative measures is also equally important. And lastly, scleral lenses can be a great asset in patients with severe lack of ophthalmos. These are my acknowledgement and my reference. Oh, and thank
Thank you
you.
so much, Dr. Eiampikul. That was a great presentation. Anybody with questions, please and put them into the chat. We'll address them at the end, but I will let us move on to Dr. Masolak for the next case.
Hello, I'm Dr. Diana Masolak coming at you from the Illinois College of Optometry here. Um, Trying to bring us back to the beginning here. Okay, so I will be talking to you about optimizing ocular health in ectodermal dysplasia. So what is ectodermal dysplasia? It is a group of genetic conditions in which parts of the body that develop from the ectoderm do not form properly. Specifically in the eyes, we see many eyelid and lacrimal system abnormalities. And there are over 100 different types of ectodermal dysplasia, and the way that it manifests can vary largely from person to person, which you will observe in these following cases here. So I'm sure you can imagine these findings can cause severe ocular dryness and inflammation with resultant chronic ocular pain, neurotrophic keratitis, corneal opacification, and more. So how are we able to help these patients? So case number 1 here, I saw at my institution with the lovely Jennifer Harthen. So this 42-year-old white female presented for a scleral lens fit due to ocular surface dryness, and her habitual scleral lenses were causing discomfort. Her history includes ectodermal dysplasia with malformation of the nasolacrimal duct OU. She says that she was born with no tear ducts, and she has a history of a dacryocysto of both lids, of both eyes, in 1985. She also has a history of herpes zoster keratitis OU in 2017 with resultant corneal scarring, left eye greater than the right eye. She does see her ophthalmologist every 2 to 3 months for these conditions. But here on slit lamp, we can see the matarosis, the inflamed lid margins and conjunctiva, and the central corneal scarring and thinning. And then when staining with fluorescein, she does also have diffuse bulbar conjunctival staining due to that exposure. And this greatly impacted how dry and uncomfortable that her eyes were feeling. Taking a look at the lenses she was currently wearing coming in, they were at least 3 years old. we can see that the right lens was touching her cornea, causing not only discomfort, but also central corneal staining. And this mechanical disruption was likely worsening the corneal scarring that was already present. She is on a regimen to increase lubrication as much as possible, as you can see here. And new lenses were then ordered with a quadrant-specific design, allowing us to modify the edges in the superior, inferior, nasal, and temporal area to better align with the scleral toricity. You can also do that in the mid-peripheral and the central areas with other lens designs. We increase the sag, of course, in order to clear the cornea and eliminate that mechanical disruption. And then we increase the diameter to 17 millimeters, providing a greater area of protection from that surface dryness and desiccation that was causing so much inflammation. Now, I know a lot of us do work with larger lenses than 17 millimeters, but for this patient's particular eye, the 17 was quite large and it did cover a lot of the bulbar conjunctiva. So we can see here that these lenses are a better fit, although we're clearing the cornea quite a bit in that right eye. You're not always going to get a perfect fit. I know it's a little excessive, but this patient traveled very, very far for her follow-ups. So the aim here was to strive for patient happiness and ocular health instead of just the perfect lens fit. This hyper decay material was used to allow for the most amount of oxygen, especially considering the thick fluid reservoir. And then we had her continue her current regimen, filling the lens with saline solution and a drop of over-the-counter gel eye drop. And after just 2 months of wear, her punctate staining fully resolved, obviously because her lenses were fitting properly and not touching the cornea. But most importantly to this patient is that her eyes felt comfortable and she was once again able to go about her day-to-day activities again. So just to highlight, this case highlighted a lens design that was larger in diameter and quadrant specific. And next we'll take a look at another route that you can go with fitting these types of lenses. So case number 2 here was seen by our colleagues, Dr. Shorter and Dr. Kwan at UIC, and Dr. Kwan will actually be speaking after me. So thank you, Dr. Kwan. This patient, 56-year-old white male, presented with eye irritation and blurred vision, as well as eye pain, right eye worse than left, with the habitual scleral lenses. His history includes EEC syndrome, which is ectrodactyly, ectodermal dysplasia, and orofacial clefts. He also had limbal stem cell deficiency, dry eye, and severe glaucoma. So he had history of a persistent epithelial defect in that left eye, resulting in a superficial keratectomy with mitomycin C of that left eye in 2022. And on slit lamp here, we can see again the irregular thickened lid margins with telangiectasia, matarosis, diffuse conjunctival injection, corneal stromal haze, as well as neovascularization involving the visual axis. What I would like you to do is to just take a mental photo of this slide to compare the ocular appearance after his treatment with the scleral lenses. Currently, he's also on a lubrication regimen, but specifically is using autologous serum tears at 20% concentration, using them twice a day OU. So a new order of impression-based scleral lenses were made, which are created by taking a mold of the eye, like we can see myself experiencing here. This is not our patient, this is me. And the same hyper decay material was used and a hydropeg coating was added, and that was just used to enhance lens wettability and deposit resistance, ultimately improving the lens comfort for him. So the diameter of these lenses were 16.5 and 16. Again, still quite large for this patient as he had shortened fornices from the chronic ocular inflammation. The serum tears were increased to 50% concentration, along with the addition of vitamin A. And he was instructed to place a drop into his scleral lenses along with his habitual saline solution. So saline first and then 1 drop of the autologous serum tear in the bowl of the lens. Vitamin A ointment was also added at night, which has been shown to increase corneal wound healing by promotion of epithelial growth and turnover and limbal stem cell differentiation, which is critical in this patient with limbal stem cell deficiency. And as I said, I wanted you to compare those previous photos to these ones. After just 1 month of wear, there was a huge improvement in patient comfort and reduced ocular inflammation. So there was a quite dramatic decrease in conjunctival injection, corneal haze, and corneal neovascularization. And this was all done without the use of surgical intervention, just contact lenses and eye drops. So this patient was so much happier. Obviously, they look better, but they were finally able to participate in their daily life activities without being in severe discomfort all the time. So the customizations I mentioned today included increasing lens diameter, using a quadrant-specific design, ordering an impression-based design, and utilizing lens materials and surface coatings to enhance the wearing experience. There are many other customizations that can be made, such as notching or adding microvaults to avoid those conjunctival irregularities, adding fenestrations to decrease lens suction and increase oxygen in the fluid reservoir, and more. But what I really am wanting to say is that scleral lenses are not only used for improving visual acuity in irregular corneal conditions. In these patients, actually, the visual acuity was not really improved much at all. The takeaway here is that they can just be used as a protective mechanism to keep the eye comfortable and to prevent further ocular surface damage, especially when used in conjunction with other treatments, such as a gel eye drop or autologous serum tears in the bowl of the lens. And most importantly, this can significantly increase the patient's quality of life. Thank you so much.
Thank you, Dr. Masolak. Masolak, wonderful presentation, a great point. You're right. We're not just improving their vision, you're improving ocular surface, which translates to way better quality of life for some of these patients with chronic illness. Coming up next, we have Dr. Katie Kwan, who will be hopping on to present her case from poster session. Thank you for coming on.
Hi, I'm Katie. I'm the current fellow at the University of Illinois, Chicago, and my case is the multidisciplinary management of neuropathic eye pain and blepharal spasm. These are the doctors I want to acknowledge who have helped to co-manage this patient. And these are the learning objectives from this case today. We'll first start with a case history. A 68-year-old male was referred for evaluation of corneal neuropathic pain in our contact lens clinic. He complained of eye pain, tearing, itching in both eyes for the past 3 years. His ocular history was remarkable for neuropathic eye pain, blepharal spasm, and bilateral cataract extraction in 2022. Some prior treatments that the patient has tried and failed includes eyelid hydrate, LipiFlow with gland expression, and IPL. Some of the topical therapies he's tried include artificial tears, compounded methylprednisolone, autologous serum tears, and erythromycin ointment. The oral medications that he's tried included doxycycline, low-dose naltrexone, and fluoxetine. On examination, our patient has visual acuities of 20/20. His pressures are within normal ranges. Slit lamp exam is remarkable for intermittent forceful spasms of the external annexa. He has insippated meibomian glands of both eyelids and poor tear film on the cornea of both eyes and PCIOLs in both eyes. The rest of the anterior segment is quite unremarkable. Neuropathic corneal pain is not dry eye disease, but patients can have comorbid dry eyes. So dry eye evaluation can assess the severity of signs and whether it aligns with the patient's symptoms and give us a better understanding of the patient's case history. The patient had diagnostic dry eye testing and lab workup done prior to his contact lens consultation with us. In his dry eye testing, he had low breakup time, and he is strongly positive for MMP9s. His Schirmer's was normal. His lab workup was negative for TSH, ANA, and Sjogren panels. What is corneal neuropathic pain? So pain perception occurs in the sensory cortex and limbic regions, resulting from a cascade of electrochemical signaling processes. It starts with unusual episodes of peripheral nociception leading to pain signals in absence of a stimulus. The cornea has a high density of nociceptor nerves that can respond to a range of stimulus. Symptoms of pain can occur without ocular signs of staining, and pain can be in response to sensitivity to light, wind, humidity, and temperature. Neuropathic pain stems from the malfunction of pain signaling pathways, which involves peripheral sensitization and central sensitization. Axonal injury and local inflammation results in pro-inflammatory mediators such as cytokines, prostaglandins, and growth factors. This activates sodium receptors and can intensify peripheral afferent pain signaling. The activation of primary afferent leads to heightened nociceptor sensitivity and causes an escalation in peripheral pain signaling intensity and frequency. This is known as peripheral sensitization. Central sensitization occurs with persistent activation of peripheral pain pathway and leads to heightened responsiveness in second orders and central neuronal system, which transmit pain signals to the thalamus and subsequently into the somatosensory cortex and paralimbic region. As a result, pain sensation can occur without tissue damage. Typically, evaluation of neuropathic eye pain involves a Papericane challenge test and in vivo confocal microscopy. Papericane challenge test helps to differentiate central from peripheral pain. Papericane would alleviate pain caused by peripheral sensitization, but it does not affect pain caused by central sensitization. If there is pain relief from Papericane installation, this suggests peripheral sensitization or a combination of peripheral and central sensitization. If there is no pain relief from Papericane, this would indicate a central sensitization. Evaluation from in vivo confocal microscopy is to assess the appearance of the corneal nerve fibers. There can be reduced nerve density, and the nerve fibers can have a beading appearance. They can appear tortuous with increase in nerve branching or have an increase in dendritic cells. In our patient, his Papericane challenge test, pre-anesthesia and post-anesthesia, his pain record was a 4 out of 10. So there was not a significant change in eye discomfort, which has some component of corneal neuropathic pain. His in vivo confocal microscopy showed that our patient had reduced corneal nerve density, which is the photo on the left. When we compare it to the normal corneal nerve pattern, which is the photo on the right, it's also difficult to appreciate in our patient, but there was also beating of the nerve fiber, which indicates swelling along nerve fibers associated with nerve distress and inflammation. Our patient's corneal topography revealed no corneal irregularity, ectasia, or scarring, and his keratometry values were within normal limits. So a scleral lens was designed for our patient using corneal scleral profilometry. The use of the therapeutic scleral lens would help to eliminate stimulation from wind, humidity, and keep the cornea hydrated to optimize corneal nerve health. We utilize corneal scleral profilometry as opposed to diagnostic fitting to be as efficient as possible and make the fitting process as comfortable as possible for the patient by decreasing the number of times we need to insert and remove a scleral lens. Our patient's profilometry also showed that there was some asymmetry and toricity of the sclera, which is indicated by the red elevated areas, and the small circle is an area of where his pinguicula is. This is the photo of our patient wearing his 17 mm diameter scleral lens with approximately 3,000 sagittal height, and that's in the left side, and then a 2,900 sagittal height in the photo on the right. We did not need to make too many adjustments to the fit of the scleral lens based off of our patient's corneal scleral profilometry, and our patient was able to successfully wear his scleral lens and reported an improvement in pain. So the goal of the scleral lens was to insulate the sensitized corneal nociceptors from environmental stimuli and shearing forces of the eyelid when blinking and hoping to help mitigate corneal pain. Our patient was also co-managed by oculoplastics for Botox injections to control his blepharospasm, and this also helps with insertion and removal of his scleral lenses to be able to get both lids wide open. Diagnosis of corneal neuropathic pain is based on the patient's history, pain, and signs of sensory deficit. So sensory deficits that we talked about earlier can be found by the confocal microscopic, which can show signs of decreased sensory nerve density or inflammation. There can also be a disparity between signs and symptoms that patient may present with pain but not have any staining on the cornea. There can also be symptoms of migraneous headaches with onset of corneal neuropathic eye pain, and blepharospasm may develop from chronic corneal nociceptor activity. Typically, corneal neuropathic pain develops from a trigger, which can include any type of ocular surgery such as LASIK, blepharoplasty, corneal cross-linking, chemotherapy, history of corneal abrasion, recurrent corneal erosion, any kind of history of chronic corneal epitheliopathy. These are all examples of triggers, but not an inclusive list. This is a list of example of pharmacotherapeutics that can be used in systemic management, but it is not a comprehensive list for managing corneal neuropathic pain. There is no single treatment that is effective. So some clinical pearls from this case is that therapeutic scleral lenses should be considered as an option for patients with ocular discomfort due to neuropathic eye pain. And a multidisciplinary management, including oculoplastics and pain management, can help patients with symptoms of ocular discomfort. These are my references, and thank you all for your attention today.
Wonderful presentation, Dr. Kwan. Now, next we have Dr. Wincy Chung presenting our last case of the night. Give her a second to hop on. And again, any questions you have on our last presentation, any previous ones, just drop them in the chat. And as soon as Dr. Chung has completed our last case, we will wrap up with those. Hi, Dr. Chung.
Hello. Hello, everyone. I'm Wincy Chung. And so I'm going to be going through my case series on using aberrometry to design higher order aberration optics, scleral lenses, in order to improve qualitative vision. So in this presentation, it will really demonstrate that vision is more than really seeing that 20/20 line. So before I start, I just want to acknowledge my mission eye care supervisors, Dr. Andrea Lasby and Dr. Sheila Morrison. I wouldn't be the practitioner I am today without them. And I also wanted to note that I have no financial disclosures. So what is higher order aberration? Well, it's a complex type of blur that is really not correctable with standard optics, our standard optics being our spherocylinder correction. And this is synonymous with a lower order aberration. Now, what differentiates lower from higher is really the order. So first and second order being lower and third onwards being higher. And this is all based on the Zernike polynomials. So Zernike polynomials are a set of functions that really describe the aberration in an optical system. If you look at figure 2, this is a simulation of what someone with spherical aberration may experience when looking at an E, but really a more accurate representation of what happens in the optical system would be figure 3, our point spread function plot, where essentially they take a point source and they demonstrate how it spreads through the optical system. Now, how is HOA measured? It's measured using aberrometry, and to get the total amount of HOA, we got to get the root mean squared. So we take the aberration coefficients, we square each one, we take the average of that, and we square root it to get basically our total HOA. So unlike most things in life where the more the better, in terms of HOA, the higher or the more that we have, it's often associated with poor visual quality. So who has HOA? Well, the truth is everyone has some form of HOA. It's just a matter of how much you have and whether you're symptomatic. So people who often complain of higher order aberration are patients who have corneal ectasias, such as your keratoconus, keratoglobus, your pellucid, or post-refractive surgeries, so your post-LASIK, post-PRK. I did also want to mention that just because you have HOA doesn't necessarily mean it's bad. We actually use HOA to our advantage in multifocal optics and orthokeratology. So in multifocal optics, we take advantage of that spherical aberration to give us that increased depth of focus. So things are clear at different distances when patients lose accommodation. And in orthokeratology, some of that aberration is contributing to that myopia control. Now, those two things are like beyond the scope of this presentation, but I did want to mention that just because you have HOA, it doesn't necessarily mean it's bad. I do want to also walk through the point spread functions over on the left. So over on the left, you can see a topography of one of the cases I'm going to go through where they have keratoconus and their point spread function of their residual like HOA wearing their standard scleral lens is about 1.25 micrometers. And he was very successful with HOA correction because he was a very good candidate. But we compare that to actually my point spread function at the bottom. I got LASIK a couple years ago, and my HOA RMS is actually a little higher than his, but I can say that I don't really have any qualms with the quality of my vision. So this is sort of a segue later on of who to choose for your candidates for HOA correction. Just because the number is high doesn't necessarily mean we need to, quote, fix it. So these are my cases. You'll notice at the top there, each case was fit differently, or the approach was different. So for case 1, we essentially take a mold of the cornea and the sclera to design the scleral lens. Case 2, we did our classic diagnostic fit in office and made adjustments from there. In case 3, we used profilometry, so a scan-based fit, where we essentially take sort of like a topography of not just cornea, but the sclera as well to design the lens. And if we look at the visual acuities, you'll notice that every eye has very good acuities, actually. Like nothing is higher than 20/30. We got 2 keratoconic patients, and our last case is status post-PRK. And I also want to point out that each patient has a very visually demanding job, and they all complain of this glare, especially when in low light conditions, and reduced vision even with a well-fitting scleral lens. Now, all these patients were deemed borderline to good candidates based on their HOA RMS. So I have 2 rows here. The top row is basically their scleral lens without an HOA correction, so the residual HOA that we're finding. Each bar graph is essentially the amount of aberration coefficients. And then the ones at the bottom row is HOA corrected HOA corrected scleral lenses. And if you compare from the top to the bottom, you'll notice that all the bars get lower, the numbers get better, and each case was very successful. The HOA optic all satisfied each patient's visual needs. The only exception to that would be case 2. If you notice in the right eye, the numbers are actually worse. So we ended up reordering a new HOA lens, but the patient was actually moving to a different province. So we had our colleague from that province dispense the lens, and the report back was that the patient preferred the HOA corrected scleral lens to the one without this HOA correction. And while I don't have the data to prove that it got better, it likely did get better. So how do we get more of these successful cases with HOA correction? Well, the series really demonstrated that any approach can be successful, and you can really choose your fit approach based on you, the practitioner, and your specific patient. I'm lucky enough at Mission Eye Care to have all these tools at my disposal, but not every practitioner has access to all these things. So really using what you have. And your patient's anatomy is really going to drive which approach you have to take. So for example, if they have like a filtering bleb, more likely than not, they're likely only a candidate for freeform type of lens. So freeform lenses also come at a higher cost. So that's definitely something you want to keep in mind when it comes to your patient's budget. I know there's a handful of patients at Mission Eye Care that are out of town or even come from different provinces and come specifically to the patient to be fitted. So really choosing the approach to get to the finish line as fast as possible with as little follow-ups as possible. And regardless of what fit approach you take, they really have to all be stable, and that includes rotational stability, and they have to be centered. So everyone on this call or webinar has fit a toric soft lens before. And you know that spherical correction is really going to be different based on where it's rotated. And I would argue with HOA correction, it's really vital that it stays in the position that it should, because if it's off by a couple degrees, it's going to cause a different result, and usually for the worst. And you also want the lens to be centered because you want that optic to cover the pupil in all light conditions, so including when they're more dilated and when dark conditions. Also choosing eligible candidates for HOA corrections, so doing that pre-screen, measuring that HOA RMS with their standard optic without the HOA correction. So in terms of numbers, there's no study out there to say, oh, this is a poor candidate, this is a borderline candidate, and this is a very good candidate. Really deferring to the company that you work with, because they have their own statistics of knowing what characteristics or what numbers would define what good or a not so good candidate would be. And really differentiating or making sure that the reduced quality of vision is due to HOA and not anything else. So no sort of opacities or diseases at the back of the eye or any sort of central visual defects. I mean, we've educated many patients before that maybe have a cataract or AMD, and they come back in complaining that their new glasses are blurry, like really educating them that the limitation to your vision is due to these things. And we want to make sure for our HOA candidates that they don't have any of these things, because then they'll be investing in HOA correction when it's limited by something else. And then same thing like I mentioned earlier, we want to target really our 20 unhappy patients, not necessarily our 20 happy patients. And we want patients or candidates that have relatively good vision, because anything higher or worse than 20/30, the reduction in vision is likely due to something else, and HOA correction will likely not help. So since my poster at GSLS, I've had a couple more HOA cases under my belt. So I did want to share this to add additional pearls to maximize success. So if you can see here, I have a separate patient. They were complaining of qualitative vision, and this is really a reminder of like how important dry eye is. Sometimes we get hyper-focused on fit and the optic that we forget. The first refractive surface is really the tear film. And you can see here very clearly down to the left that that's a very poor tear film, and that's gonna cause issues with the scattering of light, everything down the line. And then after an in-office lid microexfoliation and a steroid pulse, you can notice that huge difference in the quality of their tear film. So really managing dry eye, I have a habit of putting all specialty lenses and coatings to really help with wettability and making sure they're using the appropriate contact lens solutions that don't strip the coatings. So this is just a little summary and sort of like a checklist of what to consider before HOA correction. And this is sort of like my conclusion of really, I foresee the demand for HOA correction only increasing, because you can imagine our visual demands for when we're hunter and gatherers versus now. I mean, that's literally my position right now. And I'm sure many of you guys watching right now is just different. And as society demands more out of us in terms of how clearly we need to see, I think we're going to see an uptake or a demand for that HOA correction. Thank you for listening to my presentation.